Good morning. I'm Dr. Jose Wiley, and welcome to PeripheralInterventions.org in conjunction with the American College of Cardiology. We're transmitting live from Mount Sinai Medical Center in New York City. Today is April 16th, 8 a.m. Eastern Standard Time. As a reminder, our next CCC live case transmission will be on May 20th. Our next peripheral intervention case will be transmitted live on May 28th, and the Complex Coronary and Vascular Symposium will be held in June 10th to 13th. Welcome, Dr. Krishnan.
Welcome, Dr. Wiley. Thank you so much for sitting in for Dr. Dangas, who unfortunately couldn't be with us. Dr. Dangas has always been a great support to us. I'd like to welcome all of you for our ACC live webcast this week. And we have a real special guest here today, is our colleague, Distal Kapoor, who's part of our endovascular team here. And Dr. Kapoor has been kind enough to join us for this very difficult case. We have an incredible case here, and we're going to need a lot of time in order to do this. So I'm going to go ahead and introduce our team and get started. To my right is Dr. Karthik Guja, who's our endovascular fellow this year. We've got Ray Lascano, our endovascular nurse practitioner. We've got Elizabeth, our endovascular nurse, Ricardo, our tech, and Matthew Varghese, our interventional fellow as well, who's part of our team. So I'd like to present the case through Dr. Guja. Dr. Guja, can you go ahead and present this case?
Good morning, everyone. Welcome to the live case of April 2014. We're going to present an 80-year-old female patient with past medical history for hypertension, dyslipidemia, asthma, CAD status post bypass. And she has a history of a GI bleed, which was taken care of 7 months ago. She came in with bilateral claudication in buttocks, hip, and calf, with right more than left more than right leg. She's Rutherford class 1 category 3, and she's on Zocor, lisinopril, carvedilol, Prilosec. She's on alendronate again, silastazole, aspirin, and albuterol. She is an ex-smoker, quit 3 years ago, and she has a 60-pack history of smoking. No alcohol, IV drug use. Next slide, please. Her vital signs have been stable. Basically, significant peripheral exam is pulses are Doppler bilaterally. She had AVI PVR done, which showed 0.72 on the right and 0.44 on the left, with waveforms suggestive of aortoiliac disease. This is at resting, and the peripheral. She was brought in for a peripheral angiogram, and which showed significant stenosis of the distal aorta with a gradient of 30 across the distal aorta, and ostial right common iliac artery stenosis, which was significant, about 80%. And there was a CTO of the left common iliac with reconstitution at the proximal left external iliac. There's borderline stenosis of the left SFA, and right posterior tibial artery was also noted to be significantly stenosed. So the current discussion is about the endovascular intervention towards TASC C and D lesions, especially D lesion like this, which has bilateral iliac occlusions, as one side significant stenosis, the other side CTO, and how to approach CTO of the iliacs, especially if there is a distal aortic stenosis, how to approach towards the bifurcation iliac. And that's the plan today.
Well, thanks, Karthik, for that wonderful presentation. So guys, I want to go ahead and take you to the angiogram. Like we said, we have a diagnostic earlier on. And Karthik, can you go scene minus here, please? So what we want to do is go ahead and show you the iliac shot here. You can see here there's a little distal aortic stenosis with a tight common iliac lesion on the right side. You can see that we're a little bit above the distal aortic stenosis on the and let me just see where we are here. 1 second. Let me see where my catheter is. So our catheter is high up in the aorta here. I'm just going to leave it a little higher up, try to get a pressure. Can you flush the catheter, please? So we go scene minus. So you can see here that the lesion involves not only the distal aorta, but also common iliacs bilaterally. So you can see there's a pressure. That's what we want to see. Good. So you can see here that the lesion is a contralateral left occlusion and a right common iliac stenosis with some distal aortic involvement. So we went ahead now, and what we did was, I wanted to show you how we got access. Can you show me can you show the screen here, guys? I want to show the second screen here. So what we did was, in order to show, I want to just show you how we get access in these type of occluded lesions, because you're not going to have much of a pressure. You could see here that we use roadmap, the next one, the next screen. There we go. So we use roadmap to show you the contralateral common femoral, and then we go ahead and use a micropuncture access to go ahead and get in. So our plan today is basically, we've gone with 2 7 French sheets. We're planning on crossing the left common iliac occlusion via an ipsilateral approach, and then we are going to go ahead and possibly stent the bilateral iliac and extend it to the aorta. Now I want you guys to see my pressure waveforms. Can you show the pressure waveform, guys, the hemodynamics? So we've got one catheter inside the aorta and the other catheter in the left common femoral artery. You can see by the waveforms here, you have a gradient that's quite significant from the aorta down. Now, she started off around 180. We gave her one of neo because she became vagal, because all we did was get access and get the catheters up without any issues. So therefore, I'm not thinking anything else here. So at this moment right here, what we're planning on doing is watching her pressure hemodynamically and doing it. Our anticoagulation strategy is heparin, because we need to have some reversibility, and our plan is to start with our usual wire techniques. So with that, Dr. Wiley, I'm going to kick it to you, and we're going to start here. We have an angled bird tip catheter in my hand over a 035 stiff wire, sort of an Amplatz type wire, a super stiff wire here. So what I'm going to do is, I'm going on live fluoro. I'm just going to advance my 035 wire a little bit up, right, like that. And Dr. Kapoor is just letting it go for me and letting the wire go up, okay, as my catheter comes up. So now what we're going to do is, we're going to stop right at the level of where we think the occlusion starts. Pull out the wire, please. And now I'm going to go with the stiff angle glide. Now, the different ways of crossing this, I just want to talk a little bit about it. I'm going to ask Dr. Kapoor for his thoughts, and Dr. Guja as well. I mean, what we typically do here is, in these type of iliac approaches, our algorithm is going to be one of two things. One is first of all the approach. When do you come from above? When do you come from below? So as you know, can you go scene minus? 2 things for everybody watching at home. When you want to come from above or a contralateral approach, you need to have a little bit of a stump to be able to hang the catheter into and get some purchase. You can see here it's almost a flush occlusion, not quite a flush occlusion of the left common iliac. So although you might be able to try to go up and over in this particular case, it's probably not going to be a very favorable anatomy for you to go up and over. Second, you can talk about arm access. When you talk about arm access, you want to be able to go with a 90 centimeter sheet into the distal aorta, and that may give you enough support. But again here, because you have a very calcific lesion, as you see by fluoroscopy in a second, and you also don't have a good stump, and you have bilateral iliacs to treat, this is not going to be a favorable up and over case. From the arm. One thing you could do is put a brachial access and leave a pigtail as a target, but here, since we don't have a contralateral occlusion, we've left a catheter from the right side up in the aorta. Third thing here is, you also want to look at what your bailouts are. When you start looking at a lesion like this, okay, well, what are the bad things that can happen? Well, first and foremost, you could fail crossing a CTO, which happens to the best of us. So the point is, that's not to me a bad thing, because at the end of the day, the patient's going to be left with their symptoms. You still have a surgical option of a fem-fem bypass. But God forbid you do perforate, you'd like to have access from below to be able to use an aortic occlusion balloon and or covered stent technologies to be able to get out of this a perforated situation. So if you do fail, say the wire does not cross, which again, can occur, at that stage, what you want to do is to fix the right iliac, eliminate a gradient, and make her a candidate for a fem-fem bypass. I think endovascular first, even though this is a complex, high-grade TASC lesion, should be the first attempt made. I think most people in the proper hands would attempt an endovascular first approach before they do a bypass of any sort. Although a fem-fem bypass can be done under local anesthesia and can be done with great results. So I always try not to be too heroic, because I do know that there are good options for this patient to do really, really well. I'm going to ask Dr. Kapoor to make any comments as I just go with my wire.
No, I think Dr. Christian put it perfectly in the right sense. I mean, if you really look at the angiogram here, distally, he has enough room for him to land a sheath on his left side and then access it from there. And as rightly said, there is not enough stump and margin for the contralateral up and over access. So I guess a bilateral femoral approach is the best approach in this patient. And again, for this patient, worst case, if, like you said, if you're not able to cross the CTO for some reason, we still have enough. We still have the hybrid strategy in place where we fix the right common iliac and then do a fem-fem bypass, and the patient benefits all ways. So
I mean, I think at this stage right now, what we're doing is we're trying to get the wire forward, and I'm doing the wire really, really slow here. And you can see here that obviously the catheter is way up in the aorta. But what I'm going to do is just watch it and have a distal target for me to get to. I can see the other contralateral stenosis. And what I'm going to do here is just advance my catheter a little bit with Dr. Guja giving me a little bit of a rail. And just very gently, we're going forward with the catheter. The key is you don't want to get very quickly dissected. A little bit of resistance there, not really much. And now I'm going to go with the wire. The wire seems to be deflecting a little bit off.
Dr. Christian, what wire are you using right now?
We're using an angle glide wire here.
Okay.
Okay, that's very favorable. Mag up for me and come off come off roadmap. So it seems to be going really, as nicely as we'd like it to go. Now you've got the distal aorta, and now I'm going to go ahead and do another roadmap. And normally, guys, we don't use this much contrast. I think this is really for teaching purposes where you really want to see where you're going to enter. And I honestly, I'm telling you, I failed when I'm this close, and I failed when I'm far away. So nothing is done till it's done. Inject. So you can see here it's very favorable in our angle. So I'm going to have Dr. Guja just hold that wire and not let it go any forward, because I'd like to steer that wire towards where I want to go. Let go of my catheter, please.
Dr. Christian, when would you use one of the crossing devices out in the market?
Wire forward, please.
When you fail the stiff angle glide approach, or when will you decide I'm going to switch strategy and use any of those
roadmap
on the market?
I think you need quite a bit of experience to do a crossing device here off roadmap and go a little angled. I know that there are multiple devices that are available. Am I on coronary, guys?
No.
Huh? Okay. So as far as I'm concerned, Dr. Wiley, I think you have to be extremely careful. I think that if you are going to do a re-entry device here, you have to use an ultrasound-based device to be able to tell you where the aorta is so you can re-enter. You can try using, what's ACT? Okay, so you can try using one that's ultrasound guided to tell you which way to poke the needle. And the other way you can also do it is by using the one which does not use the ultrasound. When you use the crossing device or the re-entry device that does not use ultrasound, you have to use the calcific shadows to be able to guide you. But as you know, veins can also have some level of calcification, so it's very, very difficult for you to see which way to enter. As far as we're concerned, we have done it, yourself and myself, in this lab. However, with our excellent surgical surgeons, what we feel is for claudication and a good surgical candidate, if you do fail with an endovascular first approach, at this stage you can go ahead and do a fem-fem bypass. So we're going to go ahead and now just try to see where we are. A little bit of dye here, guys. Okay, a little more than that, guys. Okay, so you can see here I'm a little bit off. So I'm going to pull my catheter, redirect the wire. I'm going to ask Dr. Guja to pull the wire back a little bit. Okay, now advance a little bit, Karthik. Okay, right there is pretty good. Okay. How's that going? Is it smooth? Let's see. Set it up. Okay, looks like we're through. Let me see it above.
Looks like you're through, yeah.
Let me see it above. Let's see. See, you cannot get fooled. There it is. See
There
that?
it is.
You see what you saw there, how the wire moved? I want you to be very careful when you cross these lesions from below, because what happens is you contract subintimally up the aorta without knowing it. So what normally Dr. Guja, myself, and yourself, Dr. Wali, use a catheter that's a wire that's steerable, like an angle glide wire. But in this case, we felt a straight glide may be the first one to start, so we did that. If we had an angle glide, Dr. Guja can flip it, and I'm going to have him just flip the wire for me to demonstrate to all of you that we are in the aorta. You see that? You see how freely it moves? To really show you, unfortunately, it's not moving the way an angle glide would move, but I'm very confident here that we're in the aorta.
Well, we saw a wiggle as soon as you crossed the lesion.
You did. So what we're going to do is we're going to advance this in. This is the way, obviously, an important part of what we do. Let go of the catheter, please. So obviously the catheter doesn't want to go now. So, this is quite a calcific lesion, and there it goes. So we're in the aorta. Pull it out, please. So what we do now is once we cross into the aorta, we check an aortic pressure. So we're going to do this, and Dr. Guja is going to flush and make sure there's no clots. Pull it back. Great. We got nice flow. I'm going to check. I'm going to equalize our pressures to make sure that we're in the aorta. We have a beautiful aortic waveform, as you can see. Can you show the hemodynamics, guys? Thank you. You see you have a beautiful aortic waveform. And just to be really overkill it, we're going to give a little dye in the aorta, okay? So here's a little dye. Dr. Guja is going to give an injection just to tell everybody that we are in the aorta. Inject. And you can see that we're nicely in the aorta as well. So at this stage, we had a CTO of the iliac, calcific, went relatively smooth with the wire into the aorta, talked about important techniques on what to do. Now what we're going to do is now the treatment part of it. Now first thing you need to do is to secure an 035 stiff wire in the aorta. So get this up there. So we're going to go ahead. Go AP, guys, for me.
Yes.
So, Prakash, as you mentioned before, there's several complexities in this case. You have the calcified lesion in the left common iliac, you have a tight stenosis in the right common iliac, and you have disease in the distal aorta. What will be your approach? Are you going to balloon both iliacs simultaneously? Will you balloon the distal aorta first? What's your approach?
I think at this stage right now, Dr. Wiley, we know we have an occlusion of the left iliac, so we're done crossing the occlusion. Now we have to make a mental decision on our interventional strategy. We know that like you said, we have bilateral iliac and distal aortic stenosis, so the question becomes well, what are we going to go here? Show me above, guys. So how are we going to, what's our stent strategy going to be? So what I normally do here is I go ahead and get a stiff wire up into the aorta, and I'm going to do a pullback gradient from the right side. So which is going to tell me where my lesions are, okay? So let's go ahead and give me a straight catheter now, because I know I could cross this if I need to. And right now is when you're hemodynamically don't have a hemodynamic monitoring. This is when you need good nursing. You have to watch exactly what's happening with our patient. Obviously, like I said, she did vagal before. She's elderly. She's 80 years old, and as you can see, she's already bradycarding again. Is she bradycarding, guys, or is it me? That's what she does.
Yeah,
okay.
she goes down and then
so she goes in and out. So she's sleeping. Okay, good. She's comfortable. And Ricardo, our tech, is doing a good job watching her blood pressure Q minute. And now we're going to go. I want everybody to understand that this is a case where obviously you really need to know. Good. Take out the wire. You need to know what's going on at all times with your patient. When you're working these kind of lesions, you really want to make sure that if you're having a little bit of a leak, or if you had a difficult time crossing and your wire went subintimal, you might be dealing with some perforations, and you are on anticoagulation, so you need to be careful. So Dr. Guja's prepping it. We're going to zero this, okay? Once we zero it, we're going to do a pullback gradient to see where the lesions are. So you can see I'm about the level of the renals, maybe a little bit lower, so I'm going to just take it a little bit higher. So we're going to zero it now. And I'm going to do a straight pullback, Dr. Wiley, which is going to tell us how we're going to deal with this. So there's the zero. They're zeroing our pressures, which looks really good. I believe if I can, I'm red, green, blind, so I really can't. There you go. Beautiful. So is that a zero pressure?
Zeroed again.
Zeroed again, please.
The blue one.
Okay.
Blue.
Zero?
Vicky, blue.
Zero?
The one with the manifold.
There it is. Now we're zero. Beautiful. So now that we're zeroed, we can give you a much better idea of where the the stenosis is and how we're going to treat.
Dr. Christian, I have a posted question here.
Yes.
If you did not have access in any of both lower extremities, would you still done this case radially?
From a radial approach, I mean,
Yes.
if you have bilateral iliac occlusion, I mean, I think anything can be done by any approach. I really believe that you have to look at, you know, what are your bailouts in this kind of situation. From a radial approach, your bailouts are quite limited if you have no access, and if you have no access, that means, well, where are you going to stent up to? So that's a patient where you might have to put common femoral stents all the way down into their SFAs or profundas, which may not be the ideal thing to do. Those patients should be discussed with a surgeon, can either do an axillobifem or can do a aorta bifem bypass and may do just fine if they're good surgical candidates. So I think it's important to discuss this. Can you take the red off, please? I'm going to go ahead and just do a pullback now. So I'm going to do a pullback from the aorta down, right, under fluoro, so we can also mark where the gradients are. So we're coming down, coming down, coming down. You can see a heavily calcified aorta. So far, no gradient. So far, no gradient. This area, I'm suspecting maybe a gradient. No gradient. No gradient still, which is excellent. Little gradient, no gradient. Little gradient. About, what is it, about 10 millimeters? 15 millimeters?
Yeah.
15 millimeters. And then this is the area we're expecting the biggest gradient right here, which is going to take us all the way down. Okay. All right, now that gave us a lot of information, Dr. Wiley. Now, just that one move that we did with the catheter, I'm going to let Dr. Karthik get the wire up. That one move with the catheter tells us how far into the aorta we need to extend this. So you can see here that at this stage, we don't really need to extend it that far into the aorta. So now, because I've shown, good, that's fine. Because I've shown that the gradient is really at the very distal aorta into the iliacs, this may be a great case for us to do self-expanding stents into the aorta and reconstruct the bifurcation. Is she okay, guys? Okay, great. So now
you're going to stent within the plaque or above the plaque?
I'm going to try to, if you go to my aortogram, can you show me the aortogram here, guys?
We're talking about the aortic distal plaque.
Yeah, so if you could go to the aortogram, you see there's an aortic distal plaque. Freeze it right there. You see how there's a little bit of a haze and two collaterals coming off, or I should say two sacral branches coming off. Now, there was no gradient, so I am not going to make this an angiographically pretty aorta. That's not my goal. My goal here is to treat this lady's claudication, make her feel good, and do this safely and effectively without compromising any branches. Since I've proven with this physiologic test, which is a gradient test, pulling it all the way back from the aorta all the way down into the iliac, I am just going to extend the stents into the distal aorta, which doesn't have any collaterals, and be done with it. Dr. Wiley, Dr. Kapoor, any thoughts?
No, I think that makes that's a very good treatment strategy in this case. Like you said, there was not much lesion there, so minimal overlap, and treatment of the iliacs is a primary goal, and symptom
and
treatment makes
16040.
much better.
So that's a great point. See, so what we're going to do now is we're going to balloon this, Dr. Wiley. And, you know, we do serial balloons here. A lot of people would do IVUS imaging, et cetera, et cetera. What I like to do here is serial balloons. I really feel that my job here is to eliminate the gradient and nothing more, nothing less. So therefore, therefore, what I do here is go ahead with start with a very small balloon, like a 6 millimeter balloon, and then take it to a 7 or an 8 or whatever I need to. So here I'm going up with my 6040 balloon, like I said, into that distal aorta, which is right about there. And the other side, we know the iliac's a longer occlusion, so we're going to go with a 60 or 80, whatever Dr. Guja has asked for, and then we're just going to go up with two 60 balloons. So this is the stage when you're ballooning a CTO that you really need to be wary. You need to have your nurses aware of it. You're looking for three things. One, bradycardia. Second, pain. Third, hypotension. So this is where you need to have all your bailouts within reach. And I'm looking at my excellent technician, Ricardo, making sure that we have our aortic occlusion balloon, and we have a kit that I recommend all the practices to have, which is a bailout for these difficult lesions, which includes a 12 French sheath, an aortic occlusion balloon, and obviously, you know, covered stents as needed in order to be able to take care of it. Number three is I've let our surgeon know. I mean, our good surgeon, our good friend, Dr. Malik, as you know, Dr. Ferries, we've done cases live on the ACC website together, and they're aware that we're doing a difficult, potentially difficult aortic iliac case. So they're aware of this, so there's no surprises regarding if I need to call them, God forbid, for their assistance. So therefore, everybody's aware of what we're doing, and we're ready to go. I'm sorry? Is everything okay, Liz? So you can see a lot of resistance getting the 6080 balloon. ¿Dónde está dolor, señora? Aquí? Okay, in the inguinal ligament. Ricky, can you check where the pain is? Now that's a very important sign, what you just saw. We checked the pain. I'll tell you why. When I was pushing the balloon up, if she was having pain in her belly as I was pushing the balloon up, that means I'm very, very subintimal in my cross. So therefore, when I balloon this, there's a good chance she's going to perf. If she had pain in the inguinal area, that's a sheath pain, which again we expect because of the fact that she vagal. Left side by the groin.
No, in the stomach.
In the stomach? She had, in the stomach she had the pain when I was going through. So now you guys know that now she has stomach pain when we push through in the belly, in the left side. So obviously we're either going to be very, very subintimal or not. So we're going to go up very, very slowly with the balloons here, and we're going to watch the expansion.
Prakash, you mentioned that you were going to stent below those collaterals, even though right above the collaterals in the distal aorta, there's clearly a significant plaque that may be friable. Perhaps you may have thrombus. Would you consider just stenting right across it, or you will continue on your plan of sparing that lesion right above that collateral that you were talking about?
Well, Jose, I think those
to cover the entire distal aortic lesion.
I think those are probably lumbar arteries that at this stage are causing are hypertrophied because of the bilateral stenosis. I think our sacral branches, excuse me. So I think at this stage, we want to treat the gradients, and that's what we're going to treat. So now what I did, go C minus, what I did here in the last picture is to see where my balloon is in respect to the calcium. So you can see my balloon is pretty much centrally located within the calcium. So I don't think this should be a major issue as I'm concerned. If I was very concerned, I could do an IVUS here. Listen, she's going to have pain. We know that. We're doing a chronic total iliac. It's a smallish iliac. We've undersized our balloon to a 6.0. Yes? The pressure is good. So I think we're going to go up very, very slowly. I'm going to go up with the left first, very slowly. Go up. Liz, watch her. So we're going to go. So Dr. Kapoor is going up. We're counting like basically 2. Children. 1, 2. Don't ask. I like to see how they react before I ask. 3, slow. 4.
Still at 3. And
okay.
4 right there.
Okay, 4. That's fine. So you see here. Okay, we stopped it at 4, right?
Yep.
So you have a beautiful inflation at 4. Down. Poquito. Okay. So now you see that we have an inflation of the balloon to profile at 4. Now what I'm going to do, show me the hemodynamics, guys. Now we're going to look at the pressure, right? So the pressure, if God forbid we perf, is going to drop, regardless of where it is. It doesn't matter. The pressure, we're looking at the right leg pressure here, but regardless, the pressure is going to drop or she's going to vagal or anything like that. So there's absolutely nothing that's happened to our pressure here, okay? So at this stage, what I'm going to do is say to myself, okay, let me be confident. The patient is clinically stable. I'm going to go ahead and now balloon the other side. Okay, the pressures have now equalized as well. It means we got rid of our lesion. Now, Dr. Guja is going to go ahead and balloon the other side. Cycle a cuff, guys. Slowly. Yep. 5.
You going to nominal?
We're just trying to expand the lesion. Okay, there we go. That's 4. Down. So we went down with both. And again, I don't want you guys to get scared by pain. They are going to have pain. We know that. The whole point is to anticipate what's happening, okay? Now, the biggest inflation is going to be right now because we're going to go up with both the balloons in the distal aorta. So ready, guys? We're going to go up again together. Slowly now. Now you may not go up. You don't need to go up to nominal. You want to watch the expansion of the balloons in the distal aorta. Slow together. I want to count together.
2.
3.
3.
Okay, 4. I like 4. So we're stopping at 4 because I can see her reacting. And then we're done. Down. Lo siento, mama. So now I'm going to watch my pressure. I don't know why my eyes are tearing here. Oof, I got some serious allergies going on here. Show me the hemodynamics, guys.
So Prakash, can you please talk to us about your algorithm of choosing stents, whether
Now,
you're going to be using
but Dr. Wiley,
self-expanding
before
stents?
we do that, I want to show you this. What we're going to do now is we're going to sheath the balloon. We're going to take the sheath up into the aorta. A lot of pain there. I'd like to go a little bit more distal if I can. Nope. A lot of pain there. We're going to leave that there. Can you please wipe my eyes again? I'm going to go up with this balloon then. A lot of calcification, as you can see. Take off my glasses. So you can see here that we're having trouble advancing the sheath into the aorta. So now what I'm going to do is walk the balloon out on this side, and I'm going to put the dilator in. Can I have the dilator, guys? It's important for you to get control of the aorta in these kind of cases. So, ¿qué pasa, señora? ¿Dolor aquí? Where? Aquí. Aquí? Okay, sorry, lo siento. Pain in the groin. So right now, we're going to go ahead. We make sure that we don't lose wire access.
So you took the balloon out of the right?
Right, and now we're going to go with the sheath and the dilator into the aorta. You see that? Now I have control of my aorta. Okay, let's inject on the aortic sheath, guys. Okay, show me above, please. Okay, ready? Inject. So there you go. So you got a little dissection up the aorta, which we expected, which I'm not worried about. So now we have one stent in and the other sheath right on the outside. I'm trying to see where that sheath is. My eyes are burning. Wow.
Dr. Christian, what's your rationale trying to sheath those balloons instead of just pulling out the balloon?
Because if I have a perforation, Dr. Wiley, I need to be able to get my stents into the aorta. And when you have such a calcific iliac, you're going to have a lot of difficulty in terms of trying to, can you give me a wet gauze, please? In terms of trying to advance it through the calcific spicules that you have. So at this stage right now, I'm going to leave my other sheath where it is. And what I'm going to do is walk back my balloon on the opposite side. Yeah, saline on the sheath, please. Now, Dr. Wiley, the question is how to size the distal aorta. That's my question now. What do you recommend, Dr. Kapoor, Dr. Wiley, on how you're going to size the distal aorta?
I guess the first thing we got to decide if you're going to be using self-expanding stents or you're going to be using balloon-expanding stents. That will make a difference if you use a self-expanding stent. It's not that big of an issue. You could probably use a 1-to-1 ratio to each one of the iliacs. When you're using a balloon expandable stents, it's a little more complex because the distal aorta there is actually not quite big.
Dr. Kapoor, what about covered stents?
Well, I mean, usually, based on the trials done previously, especially the COBUS trial, it was shown that the covered stents work much better than the bare metal stents, especially in TASC C and TASC D lesion. So, but in this case, I guess the limiting factor will be, like Dr. Wiley said, is the size of the distal aorta, which might just limit us from placing our covered stents effectively. So in this case, self-expanding stents might work better as compared to covered stents. So
I think exactly as both of you outlined, I think the most important thing to remember here is the distal aorta. So remember, you are going to extend this into the distal aorta. I know you were worried about the distal plaque, Dr. Wiley. Myself and Dr. Kapoor have kind of agreed to leave that alone. And so therefore, what we're going to do is we're going to go ahead and just use two covered stents. There are two self-expanding stents into the distal aorta coming out. Now, what I've done is I've gone with 7 French sheets for multiple reasons. One, my bailouts, I can send my covered stents or my self-expanding stents through this. Lo siento, señora. But, yep. Huh? So the second, second is I can also inject around to see where I'm going to deploy the stents. So you can see here goes one stent right there. Let's get the second stent, guys. It may not be enough size. We might have to use another one. We'll see. Okay, so Dr. Guja has decided to go with a 12080 and a 12040 stent. I do not think that is wrong. One could always say, why not IVUS the aorta and appropriately size it? One could say, why not do this as an aortic cuff balloon, dilate the distal aorta, use an aortic cuff, and then do iliac limbs. To me, I mean, I'd like to demonstrate that this can be done with just self-expanding stent technology with outstanding results. So right here, we're just going to use 2 self-expanding stents into the distal aorta, balloon both of them out, and then go ahead and place it. So you can see here I'm going with the other one in my sheet that's in the aorta. What's the matter? In my sheet that's in the aorta.
Now, Prakash, we haven't answered the question. How are we sizing the stents that we're putting there? Are we going to be using the sum of the diameter of both stents?
Yeah,
be greater than 2/3
that's
the
exactly.
size of the distal aorta, like in coronaries, or what's your approach?
I don't think there's a definite rule here, Dr. Wiley. I think we know that the distal aorta is diseased. It's probably a 14 to 16, or maybe 18 millimeter, definitely not 18, probably 16 millimeter aorta to 14 to 16. So at this stage, I'm going to use 2 12s and do exactly what I said, the 2/3 rule, and 2/3 of the sum. So that's exactly what we're using.
Yeah, that would be safe.
So what I'm going to do now is have Dr. Guja give a little injection up top. So we're just going to give a little injection. No, on this side. Yep. So we're just going to a little test. So I want to see I'm below those collaterals, which I want to be. And you saw that retrograde dissection. So now what I'm going to do is go ahead and walk this out.
Okay.
I like that position. So I'm going to walk this back. Okay. So I'm going to have Dr. Guja deploy one, and I'll deploy the other.
Prakash, before you deploy your stent, are you concerned that the dissection may be extending a little higher, and you want to ensure that you cover?
Well, if anything, Dr. Wiley, it's a retrograde dissection, right? So once I stand, the other way. I want to see the down below. So I'm not really concerned. Good, that's a good spot. Good. Now mag up top. So I know that if it's a retrograde dissection, it should tack up, and I'm below those 2 collaterals. So what we're going to do is we're going to deploy these together. So we're going to work together here, and this is going to be a lot of fun. Every time you do these things, a lot of fun. Ray's there to adjust where we are. So push mine up, Ray. So what we do is I've got now push his up, Ray. So what we're going to do is we're going to start a little bit higher, okay? Start flaring together. It's not a perfect science, guys. That's okay. Now pull both back, Karthik. Good, right there. Okay, right there. I like it. Okay, Karthik, right there. You start deploying. Good. Now we're pretty much done. I'm done, he's done. So you saw how we expanded it into the aorta, right? Now we're going to go ahead and walk this out. Now the important part comes in. You can see a lot of tension as Karthik walks it out. Now we're going to go with 2 6-0 balloons again. Actually, we'll go with, I'm sorry? You want to go with 8s? What do you think, Jose? What size balloon would you go here? Come, walk it out.
What size is this then? You said 12?
12, but I mean, to me, I'd like to get an expansion first and then decide if I want to super expand it. So give me 2 6-0s.
I'll be comfortable with 6, yes.
Give me a shot, a picture. Inject. Okay, so we got little flow issues on the other side, which maybe we might have a distal lesion. And you can see the retrograde dissection up the aorta now. You see that?
Yep. Well, there was a lot of plaque in the vessel wall, as you see there, but
there's quite a bit of dissection now. I'm actually very surprised. I'm going to inject from above to see whether that was always there or whether that was actually created by us. It didn't look like we created it. Walk this out, deploy the rest of this. So the sheath is there, so we're just going to walk this out a little bit.
Prakash, I'm not very concerned about that dissection. As a matter of fact, there's data showing that you just have to follow them at 1, 3, 6, 12 months.
No, there's no question.
So,
I think there's absolutely no question in this particular case. There's nothing for us to do.
I will not try to chase anything.
Cycle a cuff, guys. Okay. Okay, so here goes 2 6-0 balloons. Finito, senora.
I clearly would not want to overexpand that and extend that dissection, which probably is not going to cause problems, but you don't want to overextend that dissection.
I think when I inject from above, you'll see that you won't even really see it. I think it'll definitely tack up.
So we're going up with 6-0 balloons.
Yep, first I'm going to expand my stent. Show me above, guys. Okay, there's one. Give me a pigtail wire, guys. A pigtail or a UF or whatever. Okay. Let's go up together slowly.
1 second.
Guys, I have another question here posted. It reads, when will you decide to use a bilateral kissing stents, balloon expandable versus self-expandable?
I use balloon expandable kissing stents when I'm not dealing with the aorta, and I'm curious what Dr. Kapoor, go up to nominal, not nominal, guys, slowly like we did.
2.
So to me, if I'm not planning on doing a distal aorta, moderate pain,
5.
bradycardia down. Okay, so there you saw the expansion and you saw the pain there.
Why is that? You concerned of traumatizing the distal aorta? Or
No,
what?
she was bradycardic with pain.
No, your rationale of using self-expanding stents if it involves the aorta?
Just to size it properly, Dr. Wiley. Boy, what's your thoughts?
I agree with you. In the past, we used to use kissing stents and extending into the aorta, creating a new carina. The only issue with that is that sometimes you create dissections, and we've almost eliminated them with self-expanding stents.
Okay, so give me now a pigtail catheter. Mejor? The groin is hurting, Karthik. Got it. Good. So again, as you see, when you're dealing with an awake patient, you have a lot more issues, but I think it's good because it also teaches you a lot on what's going on. Pull this back. Oh, give me a wet one. So we're just going to do a completion shot here, Dr. Wiley. And then we're gonna, like you said, unless the aorta looks super scary, we're gonna leave it be and see how she does. A little higher. Good. Way up. That's okay. Don't worry too much about forming that pigtail. You know, it is a pigtail catheter, so you should be okay with a nice look like that. Come forward. Good. All right. Let's do a DSA. That's perfect. Okay. 1 second. Let's do it pretty. All right. Ready?
1 second.
DSA. Okay. Okay, señora, no te respira ahora. No respira hondo. Beautiful.
Nice.
Beautiful.
I think that looks pretty good.
Yeah, I think it's a retrograde dissection in the plaque, and you can see there's a little bit of extension.
No big deal, absolutely.
But I think that'll definitely tack up. I'm not too worried about that. We will show it to our surgeons here, and then we'll decide on what to do. I'm actually surprised that it actually dissected that far up. You know, it's the calcification that occurred, but clearly the gradients are gone, and I think we're done here, Dr. Wiley. We'll talk to Dr. Malik and Dr. Ferries, show them what's going on. I'm sure they'll agree with us in terms of following it up with a CT, and then we'll be, we'll obviously follow up closely. She is 80 years old. She was quite limited. She really has not much health issues other than the fact that she has a little bit of COPD and whatever that Dr. Guja talked about. And I think at this stage we achieved our result. We've got runoffs before which showed the 3-vessel runoff into the right and left foot. We'll make sure that our runoffs are the same, and then we're done here. I think that's basically what we wanted to demonstrate.
Dr. Kusher, you want to speak a little bit about the patency of iliac stenting versus SFA?
Well, I mean, as we know, iliac stents, in a general rule, tend to be more patent. The patency is superior to SFA stenting. But however, we know that as the TASC classification of the lesions go up, especially with chronic total occlusions, your patencies are going to drop. In this particular lesion, with reasonable inflow, a good result, and good outflow, I think in this 80-year-old lady, I mean, the patencies are very acceptable in this particular patient. Mm-hmm. Any comments, Dr. Guja, Dr. Kapoor?
I think you perfectly put it on the head. It's just the keeping the cross-sectional area big enough, and especially with the iliacs having better than the SFA, the patency is well maintained, and it's actually shown in the data as well that the iliac's patency is higher, much higher than the SFA itself. So I think it'll fly in this case.
So, are you going to follow this lady with CTs in 1, 3, 6 month, 1 year? What's going to be your protocol for following that dissection, which I don't think is going to be a problem?
I mean, to me, I mean, we are. I mean, what I'm going to do initially is get a response from our vascular surgical team. Let them know that we have a little bit of a retrograde dissection stain. It could just be ruptured plaque with the dye tracking along the plaque. I think the initial CAT scan is going to show us a lot regarding what's happening with the distal aorta. If the distal aorta is dissected and there is a retrograde dissection, then what I may do is follow her up with serial CTs or even ultrasounds to make sure that there's no expansion. To me, I personally believe there's a calcific plaque that was ruptured while we ballooned and clearly tracked up into that. You can see there's a late tracking of dye above, which I think will tack up with time. To answer your question, I think it's all about what the initial CT shows before we make our decision.
Good. Very good.
Any comments, Dr. Guja?
So I think that's where the self-expanding stents come into play. I mean, they're nitinol stents. We were expecting that we might have some dissection because the calcification of the distal aorta. That's the reason we didn't choose balloon expanding stents, because the distal aortic size is so small. If you have balloon expanding stents and you expand them, they go up to a particular size and stop. Nitinol stents are self-expanding. They will tack up this dissection over time. And I think this is not a big issue. I think we can do initial CAT scan, as Dr. Krishnan said. And the patency rates clearly have been shown that there was a paper last year in vascular journals, which there are a lot of studies done, which have shown equal patency or more or better state patency rates of the stents when compared to bypass grafting in iliacs. Again, TASC C lesions have been rarely studied. There was one article in vascular.org which came up last year in 2013 July, which showed TASC C lesions and C lesions in iliacs, which showed equal patency as aortofem grafting. So I think we are done here, I guess. I think.
Yeah, but the problem is there is no randomized controlled data,
that's
so
right.
it's all single center ratings.
Study.
And what we look at aorta bifem versus taking a risk of this particular one is the morbidity associated with aorta bifem. Bladder injury, intestinal injury, the long recovery. And if you can do it relatively safe in an elderly 80-year-old lady like this, I think it's a very reasonable approach. But my point, and Dr. Kapoor's point, and Dr. Guja's point here, is to really show you an easy, demonstrate a way which can be done safely, looking at your bailouts, looking at your approaches, looking at what's anatomically available for you to stand, and then going ahead and taking care of it. So this is where we're at here. We're going to stop. Dr. Guja is going to tack up any issues, and with Dr. Kapoor and the distal iliac, especially by the external on the left side, to make sure there's no issues, and check the runoffs. And then we're going to call Dr. Malik, have him take a look at that distal aorta, and then probably get a CT before her discharge. I appreciate all of you tuning in and watching. Dr. Wiley, appreciate you stepping in to moderate for Dr. Dangas. Dr. Guja, thank you. Dr. Kapoor, thank you for taking the time out. And Ray, and obviously Ricky and Marichu and Elizabeth, thank you so much for all your wonderful help.
No, I want to congratulate you for showing a difficult case made look easy. There's a lot of complexities, as we discussed earlier in this case, but you made it look quite easy. Thank you so much.